Good evening from Falmouth, Massachusetts, and welcome to Joint Explorations, a virtual education series focused on joint replacement. This is our first event of the series, and we will be hosting another event focused on hip replacement on June 11th. Stay tuned for more details as we will be promoting that event soon. If you have any questions during the presentation, please submit them through the Zoom meeting. Chat. Our team will organize the questions and it will address them during our last 10 to 15 minutes this evening. If we're not able to answer your questions today, please email them at outreach@capecodhealth.org and we will follow up with you directly. Today's presentation is being recorded and will be posted next week at www.capecodhealth.org/Falmouth or #orthopedics. I'm Dr. Paul Dimond. I am the Chief of Orthopedic Surgery at Falmouth Hospital. And I did my undergraduate training at Creighton University. I did medical school at Vanderbilt University in Nashville, Tennessee. I trained in residency at the Brown University Rhode Island Hospital program. I spent a year doing a trauma fellowship at Brown, and then spent a year at the Harvard University and O. Frank Fellowship at Mass General Hospital and New England Baptist Hospital for adult hip and knee replacement and complex reconstruction. I was one of the first on Cape Cod 25 years ago to do complex hip and knee replacement and revision surgery, and to this day, I still am continuing in that vein. The mission and vision of Falmouth Orthopedic Center is to apply evidence-based standardized care to our total joint patients using an integrated care delivery model resulting in safe patient care, excellent patient outcomes, efficient and effective processes, superior patient satisfaction, and this is coordinated care through the continuum of our healthcare service. Our vision, we will provide the highest quality of safe patient care resulting in superior outcomes and exceptional patient satisfaction. And we will offer patients undergoing a total joint replacement in our community a coordinated, streamlined process across the continuum. Tonight, I'll be speaking about arthritis of the knee, and then we'll get into treatments and then knee replacement. What is arthritis? Arthritis means inflammation or swelling of the joints. There are multiple causes. Wear and tear can occur in patients as they age. There's inflammatory arthritis such as rheumatoid arthritis. And then we'll see cartilage damage in patients who have had traumatic events and infection. Osteoarthritis is by far the most common type of arthritis, and the end result is a painful and stiff joint. And we can see here, I've got the red dot on a normal knee, the femur on top, the tibia below, and the spaces there are 5 to 6 millimeters in size. That's the normal cartilage between the femur and the tibia that makes up the knee joint. To my right is a arthritic knee pre-surgery, and you can see the femur and the tibia and the two bones are now touching one another. The cartilage is stripped off, and this patient is ready for joint replacement. 23% of the American population has a diagnosis of arthritis. They're living longer, they're staying active, but also we have a heavier population now that can also contribute some to the arthritic conditions that I see. Cape Cod is a region with an older population. At the present time, I do more than 400 total joint replacements annually. We'll see arthritis in the shoulder, the knee, the hip, spine, the ankles. Lower extremity tends to be more symptomatic due to weight bearing of the lower extremities. And knee arthritis is 2 times more common than hip arthritis. So of those 400, I'll do 300 total knees and 100 total hips. What are the causes of arthritis? As I mentioned earlier, there's wear and tear, repetitive use. But keep in mind that not all 90-year-olds have the disease. So there are other factors that play into that disease process. And that, I believe, is alignment, whether we have bowing of our legs or really knock knees, These two types of positions are either varus or valgus, but they lead to increased forces on the inner or the outer side of the joint that can lead to cartilage damage and eventually pain and disability, and the need to come to see an orthopedic surgeon. Symptoms. The bone ends have nerve endings. So as the cartilage gets stripped away, we'll see the two bones grinding together, and that leads to pain. Patients will lose motion with arthritic conditions. They'll have stiffness and swelling. The body's response to that arthritic condition is to build up fluid, and that fluid we can see in the knee joint. We'll also see change in alignment. As the arthritic process progresses and the joint collapses on one side or the other, the patient or the family will notice that the patient is standing in a more malaligned position. That can lead to ligamentous instability and collapse of the joint during gait and ambulation. Treatments, I take a very holistic approach to treatments. I'm going to speak tonight a little bit about injections that I use in the office, braces that I use, some physical therapy, and then I'll close out the night with surgery and our Day Zero program here at Falmouth. So injections. The first line of arthritic treatment in the knee is steroid injection into the knee. I do it right in the office, and I typically see patients. Arthritic conditions of the knee can take a sinusoidal pattern, flare-ups and remissions. And patients will come in with a flare-up, and at that time, I'll start off with a cortisone injection, and that sometimes can settle down that inflammatory process and make significant improvements in the patient's symptoms. I'm going to talk a little about hyaluronic acid and PRP. But as I go through these injections tonight, please keep in mind that every patient is different, and the injections that I use are based on a thorough history and physical exam and a visit in the office so that I can see you, examine you, and talk to you about those various options. But I wanted you tonight to hear what we do inject into the knee. Hyaluronic acid, I refer to it as the WD-40 of the knee. It's I use something called Euflexa. It's one injection per week for 3 weeks. It acts as a shock absorber, joint lubrication. It has chondral protective mechanisms to it, and it tends to help the cartilage matrix. And I've been using this injection for 25 years. It's my step 2 for patients who don't respond to cortisone injection. And I do believe in this injection and feel that it can be very helpful as a maintenance for patients looking to avoid surgical intervention. There is a new longer-acting steroid on the market now. It's called Zilretta. I only use it for the knee. It's relatively new. Results do appear somewhat promising, and it's a steroid that's dissolved in a PLGA matrix. So what happens is that when we inject that steroid into the joint, it stays there for 4 months, and the matrix will break down, giving steroid to the joint to keep the inflammation and the arthritic condition at bay during that time. I also use in the office PRP for patients who are typically on the young side for joint replacement, or those that are very infirmed, who have a multitude of medical problems, and we'll take a portion of the patient's own blood. We'll spin that blood down in the office, and we'll inject the platelet-rich plasma into the joint. It's designed to call in new cells and stimulate a little bit of what's called fibrocartilage growth in the knee joint. And patients who go through this treatment, my results tend to be 70 to 80% seem to have a good to excellent result at 6 to 9 months. So again, it's a treatment that I use. It's something that I need to talk about with each individual patient. It is not covered by insurance, so there is an out-of-pocket payment for it. Physical therapy. With knee arthritic conditions, as I mentioned earlier, the ligaments can become weakened, attenuated, and the muscles can become weakened. So physical therapy, gentle strengthening of those muscles, can be very helpful to stabilize the joint and improve the symptoms. But I put here, I said, please be aware of the acutely inflamed joint. So when I see patients come into the office who have fluid in their knee is very hot, they're swollen. I don't rush them right to physical therapy. Typically, we'll start off with a cortisone injection and start therapy a little later when it starts to settle down and strengthen them as a preventative method. But if you just get somebody on a bike and start to let them ride, they'll start to have some more pain in the knee. So I like to let the acute inflammation settle. Physical therapy for me also can be very helpful from a preoperative standpoint. All of our patients who I'm booking for knee replacement do go to preoperative physical therapy, or they do get called by our therapy department at Falmouth. And those patients will have better postoperative recovery, less limp, and a faster straight leg raise, and they seem to get home faster. So it's another excellent process that we have here, getting all of our patients involved in preoperative physical therapy. The braces, if you can see this gentleman here on the beach, that's not me, but that gentleman on the beach, he has what's called a supple varus knee. And that knee has ligaments that are lax on one side of the joint, tighter on the other, but it actually can be passively correctable to neutral alignment. So this valgus unloader brace, if you will, allows the knee to be put into a different position and offload the portion of the joint that is uncomfortable. I also use compression sleeves as a way to give some compression of the swelling. And the patient will find with compression sleeves that they get some proprioceptive feedback. Treatment, I will adjust treatments based on many factors. A very important take-home point is that there's no one-to-one correlation between X-ray findings and symptoms. Patients will have very bad X-rays with bone-on-bone arthritis, but they may be very minimally symptomatic. And then there are other patients who have mild to early moderate disease, but these patients are severely limited, and those are the ones with significant pain that I would recommend knee replacement for. Pain and disability is the primary driver for the need for surgery, not X-ray findings. I also would recommend surgery in those patients who have malalignment problems that makes ambulation difficult. So surgical management, I'm going to talk today a little bit about knee replacement. The history for me here in Falmouth are blood conservation techniques that we use, the pain management that we're using now, and our Day Zero program, which I'm extremely proud of. So total knee replacement, I use a implant, Zimmer Biomet Persona Total Knee. I cement all my knees in place. I also use a tibial stem that's slightly longer that actually prevents loosening of the tibia and gives the initial implant great stability in all types of bone, young, healthy bone, which is stronger, or older patients whose bone is somewhat weaker. Let me go back for just a moment. I did want to show you this. I have a model tonight, and during a knee replacement, I'll resurface the end of the femur, as you can see here. We'll cap it with a special metal cap. Then on the tibia, a metal and plastic cap. So when the patient is flexing and extending their knee after joint replacement, you can see the gliding motion and no longer the two bones grinding together. And therein lies the treatment for knee arthritis. Welcome back. Sorry for any technical difficulties, but I just went back to the slide that I was just talking about. I do a Zimmer knee Persona. I cement my implants in place, and I use a longer stem to try to preserve the strength of the tibia to the implant bond. So I think I did show you this. I hope you saw it. This is, we fashion the end of the femur, and you have you flexing and extending where there's a metal tibia and a plastic liner, and therein lies the improvement of the symptoms because it's no longer grinding bone on bone. And during the operation, I'll tension those ligaments to the appropriate tension, so there's no longer any instability. So we're moving towards outpatient total knee replacements. I typically started this with younger patients who had fewer medical problems. I'll talk a little about the pain management and our collaboration with anesthesia. I've been able to manage preoperative expectations rather than, as you can see on the left, what it used to look like. All of these patients would get epidural anesthetic, be admitted to the hospital, and they would have a knee moving machine. And that required a lot of time in bed. And we've found now that patients who are getting up, moving, there's less risk of complications, deep vein thromboses, abdominal complications, and pneumonia. So we're getting patients up, we're getting them out of the hospital. And those patients who do have multiple medical comorbidities, such as cardiac issues, pulmonary problems, I typically let those patients stay overnight to monitor those medical issues to prevent any early on complications. So you can see the results of our Day Zero program. This number continues to grow, and the trends are growing month by month. Over 150 patients. 5 of those patients who we initially had as Day Zero did have to stay overnight. They had some mild blood pressure issues, but we continue to send a larger and larger percentage of those patients home. And again, as I mentioned on the last slide, less risk, and these patients are much happier. I call the patients at night after their surgery, and I'm getting some incredible feedback from these patients. They love being in their own home. They're not being disrupted by nursing staff for vital signs throughout the night. They eat their own food, so it's been a really great program. So how have we been able to do it? It's a multimodal pain management. All of the patients before surgery will get 1,000 milligrams of IV Tylenol. I'll give them Celebrex 400 milligrams, which is an anti-inflammatory before surgery. And as you can see here, this is our anesthesiologist doing a adductor canal block, which blocks the saphenous nerve for anterior knee pain, but it spares the quadriceps muscle so the patient can still actively flex and extend their knee after surgery. And this allows them, again, to ambulate with good strength. So we are also doing, and I found this to be a very important piece of this pain blockade. We do the IPAC block, which is done by our anesthesiologists. And again, I'd like to shout out to thank you to our anesthesia team for these good work that they've done. So we infiltrate between the popliteal artery and the capsule of the knee, the sensory branches, and spares motor branches of the perineal nerve, and prevents posterior knee pain, which was a bit of a problem for patients as they would wake up. They get pain behind the knee. It was hard for them to get up and walk with that. So now that pain is being blocked very well. And these blocks will last 48 to 72 hours. Also, intraoperatively, I like to have every one of these patients get a spinal anesthetic. They are awake but sedated. It's short acting. It lowers the blood pressure slightly, but it prevents bleeding with that lower blood pressure. It allows me to run my tourniquet pressure lower so they don't get thigh pain as much. So this, when they wake up from this, and the operation itself only takes me about an hour and a half. Total time that I have the tourniquet up is between 45 and 50 minutes. So we like to do it so that the patients don't have the tourniquet up and can have less pain after that operation. So we're using minimal incisions now, less soft tissue disruption, which also helps postoperative pain. And I'm using a medicine now over the last 3 to 4, maybe 5 years. It's called tranexamic acid. It's a blood conservation. We do it intravenously, preoperatively, and when I let the tourniquet down, it prevents clot breakdown. And we use it now, I would say 99% of the patients who I'm doing the replacement on, we're seeing much less transfusion risk, and this will decrease the swelling postoperatively, also decreasing their postoperative pain. And finally, the last piece of the puzzle for us, we use something in the joint. It's called Exparel, and you can see here at the corner of the slide that milky solution. It's lysosomal marcaine that I inject around the joint. We inject it in the medial lateral collateral ligaments. I inject it in the posterior cruciate ligament, and then down along the proximal tibia and up into the quadricep muscle that I operate on. This also, again, belt and suspenders, a lot of different things at a lot of different levels, really helps their pain management. Less nausea and constipation. The 2 total knees that we sent home today walked without any pain an hour after surgery. Recovery room, they're ambulating. They have their first cup of coffee, check their vital signs. Physical therapy will come down and work with them. And that's where they get to meet their caregiver for their home treatment, and they get a visit from the VNA. And I try to give these patients a call at night. And again, the nighttime call is to kind of make sure they're doing well, they have all their questions answered, and that their pain is under control. And my office the next day will reach out to them as well, talk to them, make sure they're doing good, and that they've had the visit from the VNA services. So the preoperative teaching class, I'm also very proud of this. We've had 25 years of preoperative teaching, either in my office initially or now taken over by our Brendan, who's our physical therapist, and the VNA services, Suzanne, our case management specialist. They review the entire process from the office through the recovery process with these patients at this class. The expectations, how they'll hydrate, what they do for skin preparation and skin cleaning before the surgery, and then talks a little bit about rehab. And I like to say it's been an absolute home run. This has been great for the patients to really understand that they meet other people who are going through joint replacement. They really understand what the expectations are, what they're getting into, what their caregiver is expected for them. So it's another exciting piece of the puzzle for us. So I'm also wanted to report that Falmouth Hospital is proud to be certified as a total joint center of excellence for total hip, knee, and shoulder replacements. We reobtained this, or we've had it, but we just were recertified recently. And again, extremely proud to be able to deliver that kind of care to the Falmouth as well as Cape Cod community. So it was an excellent achievement from multiple people played roles, from physicians, our physical therapists, administrators, office managers, all of that played a role in this. So we'd like to thank everybody who played a role in it. So to request a consultation, you can go to www.capecodhealth.org/ortho, or our office number is 508-457-4900. And thank you. And again, thank you to Cape Cod Healthcare for putting this together. Thank you for all of the AV team here who are with us and working through a couple of glitches, but it all turned out great. So thank you. Oh, yes. Any questions for me? I'll take some questions from the audience. So the first question is, how long does a knee replacement surgery typically take? From the time the patient rolls in the room, let's say at 8 o'clock in the morning, from the spinal that they'll get to the prep, the drape, it's usually about an hour and a half. The actual surgical time for me is about 45 to 50 minutes, and then we'll close the wound up and get the patient out of the operating room. The next question, how long would I try steroids before considering surgery? I would say that if I'm injecting more than 2 or 3 times a year of steroid or the other injections that I mentioned tonight, I start to talk to patients about considering an operation. If they're still limited and they are not getting more than 6 months to a year of benefit from the cortisone injection. What is a typical recovery timeline? Typically, I have patients on a walker for a week to 10 days, and I'll transition them at the 10-day, 2-week mark to a cane. Patients who I'm operating on the right knee, I usually wait 3 to 4 weeks before I start them driving. Left knee, I'll let them drive in 2 weeks if they're not on any pain medicine at that time. And usually offer all assisted devices by 4 weeks. 6 weeks, light golf balls, 3 months pickleball, and 6 months skiing down a mountain. So that's recovery. How long after knee replacement can patients go upstairs? That's a great question. I let patients go upstairs the day of surgery. Let them go up that day because I want them, before they go home from the recovery room or from the PACU, I want them to be able to get in and out of bed themselves, up and down some stairs, in and out of the bathroom, and to be comfortable before they go home. How often does a patient see a doctor during recovery? I'll see patients at the 10-day, 2-week mark, and then I typically see them at 6 weeks after their surgery, 3 months, 6 months, and a year follow-up. And during that time, and now what we're doing is we're doing a questionnaire for all our patients, which is a Medicare requirement. We're getting all of the data, what their pain like is, and their functional abilities are before surgery. And then we'll get that at the year follow-up. So we're putting all of that data into our computer system. And I think it's a nice way to look at the way patients are recovering. Can I get a knee replacement if I'm obese? The answer to that is a bit long-winded. I would say that if patients have a BMI over 40, I like to encourage them to get that body mass index down to 35 to 38. We have had discussions about Wegovy or stomach operation to get their weight under control before surgery, because if their BMI is over 38 to 40, I'll see a higher risk of infections, ligamentous injuries during surgery, wound drainage. So yes, you can, but I'd like to have a discussion with a patient who's overweight regarding weight loss program. I like to optimize all of my patients before surgery. I don't let any of them smoke. I like to prevent any nicotine use because that can hurt the blood supply and prevent wound healing. We like to get the diabetes and the A1C under control. All of their cardiac as well as pulmonary issues need to be managed. And I feel that if those patients are managed preoperatively, they tend to do better. I am 86 years old. Am I too old for surgery? The answer to that is typically I have a chronological age cutoff of around 85. However, if patients are 86 going on 75, that's a lot different than when you're 70 going on 95. So it's a discussion with each individual patient. I would say that the oldest patient that I've done is 90. That particular patient was sailing her boat in the Bahamas the following year. So to that end, we want to make sure that they're physiologically good and not necessarily chronologically a definite cutoff. So 86, I would still operate, the answer to that question. Yes. Do you do total knee replacement revision surgery? Who's a candidate? The answer to that is yes, I do revisions. I'm one of the few on the Cape that does do revision work. Typically what happens with knee replacements over time is that the plastic liner will wear, and as that plastic liner wears, those particles get into the joint. Those particles will start to wear away the bone, and that weakens the bone and subsequently weakens the implants. So if they come in and they have a workup, which I always do for everybody, it's an infection workup to make sure that implant is not infected. It's not infected, it would be a one-stage revision, removing the old implants and then re-implanting the implants, typically with longer stems, special wedges that are designed to grow into the bone. If it's an infected revision, the way I handle that is removing all the implants, placing an antibiotic impregnated spacer, and then giving 6 weeks of IV antibiotics and then re-implanting patients typically at the 9-week time frame. So, would a lumbar spinal fusion prevent this replacement operation? 2 comments about lumbar spinal fusion. No, not in any way it would prevent knee replacement. It may make the spinal anesthetic a little difficult. I would say that patients who I'm operating on for hip replacement who've had prior spinal fusion, I use a special type of implant called a dual mobility to prevent dislocation in those patients, because they do have a slightly higher risk of dislocation because they've lost spine mobility, so they have to move their hip more, and that puts more forces on the joint. So I alter my surgical technique for patients with spinal fusions on the hip side, not necessarily on the knee side. Is knee replacement often bilateral? That's a great question. I used to do bilateral knee replacements much more frequently early on in my practice. I would say that I would still do it. It'd have to be the right patient, very healthy, very motivated. I've kind of stopped doing it to some extent because I felt that those patients had a higher incidence of medical complications postoperatively, abdominal problems, clots, pneumonia, stuff like that. And because the pain management is so good with the one knee at a time, I'll typically try to convince patients into do one knee replacement, come back healthy, and do the other one about 3 to 6 months later when they are metabolically ready to go. Thank you again for joining us tonight. Please, if you're not able to answer the questions tonight, please go to outreach capecodhealth.org, and I will answer your questions and we will follow up with you directly. Again, thank you all for attending. I appreciate your time and attention, and if I can be any help orthopedically, please let